Today we are going to talk about veterinary anesthetic agents in the order you would usually give them: premedication, induction, maintenance, and recovery pain control. The important thing is that these are study level ranges, not fixed recipes, because anesthetic doses change with species, age, health status, route, premedication, procedure pain, and monitoring. Before anesthesia starts, the first goal is usually analgesia and calming. Opioids are often given early because pain control should begin before the painful stimulus. Full mu opioid agonists like morphine, hydromorphone, methadone, oxymorphone, and fentanyl act mainly at mu opioid receptors in the brain, spinal cord, and peripheral tissues. Activating the mu receptor decreases pain transmission, but it can also cause bradycardia, respiratory depression, vomiting, nausea, dysphoria, or panting in dogs. Hydromorphone is commonly around 0.05 to 0.2 mg per kilogram IV or intramuscular, and lasts about 2 to 4 hours. Methadone is commonly around 0.2 to 0.5 mg per kilogram IV or intramuscular, and lasts about 3 to 6 hours. Morphine is commonly around 0.2 to 0.5 mg per kilogram intramuscular or subcutaneous, and lasts about 3 to 6 hours. But rapid IV morphine can cause histamine release and hypotension, so it is used carefully. Fentanyl is also a full mu agonist, but as a single IV bolus it is very short, often around 2 to 5 micrograms per kilogram and lasting only about 20 to 30 minutes. So for major pain it is often used as a constant rate infusion instead. Buprenorphine is different because it is a partial mu agonist. It binds strongly to the mu receptor but does not activate it as completely as hydromorphone, methadone, morphine, or fentanyl. In cats, it is commonly used around 0.01 to 0.03 mg per kilogram IV, intramuscular, or transmucosally, and it often lasts about 6 to 12 hours. That makes it useful for mild to moderate feline pain, dental pain, or outpatient-type procedures, but it should not be your only plan for severe orthopedic or major abdominal pain. Butorphanol is different again because it is mainly a kappa agonist and mu antagonist or partial antagonist. In dogs and cats, it is commonly around 0.1 to 0.4 mg per kilogram, and in horses it is often around 0.01 to 0.02 mg per kilogram IV. Its analgesia is short, usually about 1 to 2 hours, so it is useful for mild pain and sedation, especially in horses when paired with an alpha-2 agonist, but it is not enough for major surgery. After analgesia, you may add a tranquilizer or sedative. Acepromazine is a phenothiazine tranquilizer that blocks dopamine receptors and also blocks alpha-1 adrenergic receptors, which causes vasodilation. In dogs and cats, it is often around 0.01 to 0.05 mg per kilogram intramuscularly or subcutaneously. In horses, it is often around 0.02 to 0.05 mg per kilogram IV or intramuscularly. It lasts a long time, usually 4 to 8 hours and sometimes longer clinically. It is useful for stable, anxious dogs or horses when you want long calming and smoother handling, but it has no analgesia, is not reversible, and can worsen hypotension in dehydrated, bleeding, shocky, or unstable patients. In breeding stallions, it is used cautiously because of the risk of penile prolapse or priapism. If you need stronger sedation and some analgesia, alpha-2 agonists are often next. Dexmedetomidine, medetomidine, xylazine, ditomidine, and romifidine act on alpha-2 adrenergic receptors in the central nervous system. They decrease norepinephrine release, which produces sedation, analgesia, and muscle relaxation. Dexmedetomidine in dogs and cats is dosed in micrograms per kilogram, commonly around 1 to 10 micrograms per kilogram IV or intramuscularly, depending on the patient and desired depth. Strong sedation often lasts about 30 to 60 minutes, with residual effects sometimes lasting closer to 1 to 2 hours. These drugs are powerful, but they commonly cause bradycardia, vasoconstriction, and decreased cardiac output, so they are best for stable patients and are used cautiously or avoided in shock, severe heart disease, major dehydration, or poor perfusion. In cats, xylazine is also important to remember because it can induce vomiting, which is why it has historically been used as an emetic in cats. Dexmedetomidine can also induce emesis in cats, but alpha-2 emesis in cats is not the same as a routine anesthesia plan. You still have to think about the patient, toxin, timing, aspiration risk, and cardiovascular effects. In dogs, the classic veterinary emetic is apomorphine, a dopamine agonist that stimulates the chemoreceptor trigger zone. It is commonly used around 0.02 mg per kilogram IV or around 0.03 to 0.1 mg per kilogram subcutaneously, and vomiting often occurs within about 5 to 10 minutes. Apomorphine is mainly a dog emetic because it is less reliable in cats, while xylazine and dexmedetomidine are more associated with emesis in cats. In horses, alpha-2 agonists are a major foundation of sedation and anesthesia. Xylazine is often around 0.3 to 1.1 mg per kilogram IV and lasts about 20 to 40 minutes. Detomidine is often around 0.005 to 0.02 mg per kilogram IV and lasts about 45 to 90 minutes. Romifidine can last around 60 to 120 minutes and may be helpful when you want standing sedation with less head drop. A classic standing horse sedation plan is detomidine or xylazine with butorphanol, because the alpha-2 gives the heavy sedation and the butorphanol improves analgesic sedation. In ruminants, xylazine is much more potent than in horses, so cattle, sheep, goats, and camelids need much lower doses. In cattle, xylazine may be around 0.02 to 0.05 mg per kilogram IV for sedation, with effects around 30 to 90 minutes depending on dose. Because ruminants are prone to regurgitation, bloat, hypoventilation, and positioning problems, standing sedation plus local anesthesia is often safer than full general anesthesia when possible. Benzodiazepines usually fit into the plan either as part of premedication for fragile patients or as part of induction. Diazepam and midazolam act on GABA receptors by making GABA work better, increasing inhibitory chloride signaling in the brain. They provide muscle relaxation and anticonvulsant effects, but they are not strong pain drugs and they may cause excitement in healthy young animals if used alone. Diazepam is commonly around 0.2 to 0.5 mg per kilogram IV in dogs and cats and lasts about 20 to 30 minutes. Midazolam is commonly around 0.1 to 0.3 mg per kilogram IV or intramuscularly and lasts about 30 to 60 minutes. Their major advantage is minimal cardiovascular depression, so they are very useful in old, sick, neonatal, weak, or unstable patients. In horses, diazepam or midazolam is commonly paired with ketamine for induction, often around 0.05 to 0.1 mg per kilogram IV, because ketamine alone causes poor muscle relaxation. Once the patient is premedicated, induction is the next step. Propofol is one of the most common induction agents in dogs and cats. It acts mainly by enhancing GABA receptor activity, rapidly increasing inhibitory signaling and producing unconsciousness. It works within seconds IV and usually lasts about 5 to 10 minutes after a single induction dose because it redistributes quickly. In dogs and cats, it is often titrated around 2 to 6 mg per kilogram IV, with the lower end used in well-premedicated patients and the higher end closer to unpremedicated patients. It gives smooth induction, but it can cause apnea, respiratory depression, and hypotension, especially if it is given too quickly or if the patient is not well supported. Alfaxalone is another induction agent that acts at GABA receptors, but it is a neurosteroid anesthetic. It also works quickly IV and usually lasts about 5 to 10 minutes after a single IV induction dose. In dogs and cats, it is often around 1 to 3 mg per kilogram IV when premedicated, and higher doses may be needed if unpremedicated. In cats, intramuscularly alfaxalone can be used in some sedation protocols, often around 2 to 5 mg per kilogram intramuscularly depending on the combination and temperament. It is especially useful when you want a short-acting injectable agent, or when handling a fractious cat, but like propofol, It can still cause apnea if pushed quickly. Ketamine is different because it is a dissociative anesthetic. It primarily blocks NMDA receptors, which decreases excitatory glutamate signaling and creates a disconnected, cataleptic anesthetic state. Glutamate is the most abundant excitatory neurotransmitter in the brain, powering over 90% of all synaptic connections. As a chemical messenger, it stimulates nerve cells into action, driving vital cognitive functions like learning, memory, and neuroplasticity. Ketamine provides somatic analgesia and tends to preserve heart rate and blood pressure by supporting sympathetic tone. In dogs and cats, ketamine induction combinations are commonly around 2 to 5 mg per kilogram IV, or higher by intramuscular route depending on the protocol. IV effects often last about 10 to 20 minutes, while intramuscularly effects can last closer to 20 to 40 minutes. The downside is that ketamine causes muscle rigidity and poor muscle relaxation, so it is usually paired with midazolam, diazepam, or an alpha-2 agonist. In horses, a classic field induction sequence is alpha-2 sedation first, then ketamine around 2.2 mg per kilogram IV with diazepam or midazolam. This typically gives about 10 to 20 minutes of anesthesia, which is why longer procedures need maintenance anesthesia. Etomidate is an induction drug you choose when cardiovascular stability is the main concern. It acts through GABA receptors and produces unconsciousness quickly, but it causes less myocardial depression than propofol. In dogs and cats, it is often around 1 to 2 mg per kilogram IV and lasts about 3 to 5 minutes. It is useful in very sick patients or animals with poor cardiac function, but it can cause myoclonus, vomiting, pain on injection, and adrenal suppression. So etomidate is not usually the default drug for a healthy patient. It is the drug you think about when the heart is the reason you are worried. After induction and intubation, maintenance usually means isoflurane or sevoflurane. These are inhalant anesthetics, so they are not dosed in milligrams per kilogram. They are delivered as vaporizer percentages and adjusted to effect. Isoflurane is commonly maintained around 1 to 2.5% in oxygen depending on the patient, procedure, and premedication. Sevoflurane is often maintained around 2 to 4%. Sevoflurane has lower blood solubility than isoflurane, so animals usually change depth faster and recover faster. Both drugs cause dose-dependent hypotension and respiratory depression, and neither provides meaningful analgesia. So if a patient reacts to surgery, the answer should not automatically be to turn up the vaporizer. Often the better answer is to improve analgesia with an opioid, local block, ketamine infusion, lidocaine infusion in appropriate species, or an NSAID when safe. During maintenance, constant rate infusions can reduce the amount of inhalant needed. Fentanyl CRI is useful for severe pain because fentanyl as a bolus fades quickly, but as an infusion it gives continuous full mu analgesia for as long as it is running. Ketamine CRI at low doses can help reduce central sensitization through NMDA antagonism, especially when wind-up pain is a concern. Lidocaine CRI is commonly used in dogs and horses for analgesia and inhalant-sparing effects, but it is used cautiously or avoided in cats because cats are more sensitive to toxicity. These infusions do not have a single duration like an injection. They last while they are running, and their effects fade after stopping based on metabolism and redistribution. Recovery is what pain control has to continue. The patient may be awake, but that does not mean the painful stimulus is gone. Dogs commonly recover with an opiate such as methadone, hydromorphone, or buprenorphine depending on pain level, plus an NSAID if renal function, hydration, blood pressure, and GI status allow it. Cats often do well with buprenorphine for moderate pain, but severe pain may need methadone, hydromorphone, fentanyl, or additional multimodal analgesia. Horses often recover with NSAIDs such as phenylbutazone or flunixin when appropriate, plus local blocks, alpha-2 sedation if needed, and careful recovery monitoring. Ruminants often rely heavily on local blocks and NSAIDs such as flunixin or meloxicam where appropriate, because standing comfort and rumen function matter a lot. So the order is simple: premedicate with analgesia and sedation, induce unconsciousness, maintain anesthesia, and recover with continued pain control. Full mu opioids like hydromorphone, methadone, morphine, and fentanyl give stronger pain control for hours depending on the drug. Buprenorphine is a longer-lasting partial mu agonist for moderate pain. Butorphanol is a short-acting kappa drug for mild pain and sedation. Acepromazine lasts a long time but has no analgesia. Alpha-2 agonists give strong reversible sedation and analgesia but can decrease cardiac output. Benzodiazepines relax fragile patients with minimal cardiovascular depression. Propofol, alfaxalone, ketamine, and etomidate induce anesthesia quickly, while isoflurane and sevoflurane maintain it. The best protocol is not the biggest drug combination, it is the sequence that matches the species, procedure, pain level, and cardiovascular reserve.